as I said, that it is there's acute trauma. There could be acute trauma, maybe something like somebody experiences some natural disaster, okay, or maybe rape. So that would count as an acute trauma. Chronic trauma would be if somebody is experiencing domestic violence or interpersonal, intimate partner violence for a period of time, or if a person or people are living, the ones who are living in a very high conflict, political conflict zone or combat zone, that would count as a chronic trauma. Complex trauma is something which is usually things that happen starts at a very early age during the developmental period. For example, a multiple experience or for a prolonged period of time, if a person has experienced child sexual abuse, or even excessive extreme emotional neglect or emotional abuse, that would count as complex trauma. Vicarious or secondary trauma would be something like, maybe you yourself, you are not the one who have experienced the traumatic event, but for example, a child grows up seeing a lot of intimate partner violence between his or her parents, that could count as this. And multi-generational trauma is something that keeps happening over the period of time and across over the generation. Okay, so in any idea about what this two picture could mean when we talk about trauma? If anybody can unmute your, I don't know if you have the option to unmute yourself.
They can raise their hand. I will unmute them.
Okay, okay. Okay, I'll just, is there any response? Anybody?
Yeah, there is a couple of responses.
Okay.
One is by Atri Das, acute versus chronic trauma, and one is by Anirudh, who says folk. Acha, he's being funny. He just mentioned his forks and spoons.
Okay.
Uh,
Okay, so basically, what it means is this is the concept of big T trauma and the little t trauma. So, for as I was saying earlier, that the older textbooks would talk about how there are significant traumatic events, like, for example, natural disasters, major accidents, rape, violence. These are the typical events that causes trauma. But now it has come into the understanding that it is not always a big event that can only cause trauma. Even smaller invalidations, emotional abuse, neglect, smaller things can also cause the trauma. So it's basically, this is how this is explained. The concept of little and the big T trauma is explained, that if you hit yourself with a knife, obviously it is going to leave a deep cut. But if you do it with one fork once, it may not cause that kind of an impact. But if you keep doing it with multiple forks for a longer period of time, that is also going to have an impact. So it is not necessarily that the event has to be a very big thing to cause a traumatic experience. It could be multiple smaller things also that could leave an impact. So that again highlights how the event is not important in the experience of trauma. It is the subjective and the personal experience, or the meaning that a person makes out of the traumatic experience, is what trauma is. Okay, so we'll try to understand the trauma reactions based on these four categories. So to start with, the emotional reaction. So the first thing is denial. So often after trauma, after the traumatic experience, an individual feels extremely numb, doesn't know what is going on, uh, can dissociate from the reality and just be in complete denial of the entire scenario. Anger is a very common reaction to trauma. Anger towards self, anger towards the environment, anger towards the fact that I'm so helpless and so overwhelmed. Agitation and irritability, confusion, disgust. A lot of times self-disgust, especially in cases of child sexual abuse, rape, sexual assault. It's very, very common in self-disgust. If later we have time, I have a very interesting case of exactly this disgust and self-disgust component of trauma, we can take it up after the topic. Obviously, fear and anxiety, something that we'll talk in much detail here. Shame, sadness, guilt, grief, which is often complicated grief, which is not resolved, not processed, remains as a traumatic experience. There's a lot of frustration, again, with the feeling of that helplessness, that overwhelmingness, hopelessness, that this is how it is going to be and there's nothing getting better from here. Numbness and blunted affect. Moving on to the thought processes. So there could be intrusive thoughts. It could be two types. Most commonly seen are, one is where the person keeps getting repeated thoughts of the traumatic experience, of the traumatic event, which we often can see in the form of flashbacks, or they, because they are getting so much intrusive thoughts, there could be startle reaction because of that. And there could also be an intrusive thought which has more of an apprehensive nature. So because of the traumatic experience, they have a lot of intrusive thoughts about a lot of what ifs and whatnots. Cognitive biases. I mean, every one of us have our own set of cognitive biases. Nobody is free from it. But trauma tends to increase the number of cognitive biases. So the number of the more you, if a person who has been traumatized is a trauma survivor, any triggering or any threatening stimulus would be interpreted with maybe catastrophization, magnification, generalization, overgeneralization, and so on. So trauma also changes the way you view the world, the way you view yourself, the way you view or perceive your significant others and the future and everything. That's why it's mentioned as cognitive triad. There's an excessive amount of guilt and shame associated with trauma. And again, with that first thing that we mentioned, talked about that how there's always a thought that if I did something, I could have prevented. For example, if a person who has went maybe for a party and on the in the process, in the venue, or in the way on the way, maybe experienced sexual assault, and then the person would start blaming themselves that, if I didn't go there, or if I avoided, or if I didn't go alone, or didn't make it that late, maybe I could have prevented this. So this is very important to understand, especially when you are adopting a trauma informed care approach, because you have to understand these violences, this assault, and all of these things. This is a very systemic problem. And even though the trauma reaction is very personal, but the cause of it is very systemic. So actually there is nothing that you as a person who have experienced this can do anything about it. So once you also believe it, it will be easier for you to make your client believe the same thing. Of self-harm could be both ways. One is to actually end life, which could be suicidal in nature, or it could also be just to induce pain and numb yourself from the emotional pain. Okay, so it could be both ways. So with the behavioral patterns, there's avoidance. So again, so if a person has experienced sexual assault at while going to a party at night, there could be a tendency to avoid any such future occurrences. Or if somebody has met with a major car accident and has lost a close one, that person could also be avoiding to sit on the driver's seat, or even to the extent of not even traveling in a car, would rather prefer walking, or not even stepping out. Extreme forms of trauma experience can go to that extent, that where they don't want to travel any further anymore. Self harm, as I said, just wrist slashing or burning themselves, skin pricking. I had this client who was a trauma survivor. She has grown up seeing her family environment was extremely abusive. There was a lot of domestic violence going on, and she also, while growing up, received a lot of critical comments. She being a girl, she was criticized, and her mother was held responsible for a lot of misfortune and everything. So it was a very, very traumatic uh, environment that she grew up. And I remember when she came to me for the first time, when I saw her, she was all fine. Like, she was talking to me. So her mother had got her with the complaint of her deteriorating academic performance. But while I was talking to her, she spoke like everything was fine, and yeah, I don't find it interesting, I don't understand things, I can't recall things, I can't remember things, that's why I'm not scoring well and all. She kept talking about, okay. And only much later I found out that how she had this tendency to, she would always uproot her nails, her toenails. So I found that out because one day when she came to see me, she came limping. When I asked her, that is when her mother said. And then I saw, so there was particularly the thumb toe, the nail that she used to uproot. So there was literally, I mean, there was with full senses she would just take that nail off, and she told me that it gives me it's so painful, kind of shuts down that entire constant, that flashback that is going on now, even though I'm not staying in that kind of an environment. But I keep, every time my mother comes and says something to me, I just go back to that phase, and then I do this. And then she would apply nail polish on just the skin to cover that. So the self harm could go to this extent, is what I'm trying to say. There could be substance use. Now, along with substance use, there could be multiple ways of behavioral addiction currently as well. Inactivation or retardation, where the person stops doing everything that the person likes doing, or not finding anything any more pleasurable. Frequent crying, shouting, yelling, any form of emotional dysregulation. And physiological reactions would be, as I said, startle reaction, which is very, very common in trauma survivors. Panic attacks. This again wouldn't. If you see a patient with a multiple panic attacks, and it's very, if it qualifies the criteria as per ICD and DSM, and we give a diagnosis of panic disorder, would we be doing a justice to that client? Because all these panic attacks could be just because of trauma reaction, and if we deal with that trauma, if we work on that trauma, maybe it is not a trauma, a panic disorder, a diagnosis, it could be something else. Sleep disturbances, which could be in the form of intermittent, disrupted sleep, non-restorative sleep. It could be difficulty in falling asleep because of the ruminations. There could be experience of a lot of night terrors and nightmares. There's loss of appetite. Also, in the behavioral reactions, I think that at the same time, when I'm talking about loss of appetite, binge eating can also be another reaction, trauma reaction, that would come under a behavioral, or maybe to an, I mean, it's very difficult to segregate all of this. It's a lot overlapping. Decreased energy level, hyperarousal, and hypervigilance. This is kind of the crux of trauma, and how that maintains psychopathology across clinical conditions. Physical pain or multiple types of chronic headaches. So a lot of women might come to you with purely somatic complaints, and it would appear purely somatization or even dissociation. But when you go deeper, you will find that there is domestic violence, there is marital rape, or there has been child sexual abuse at a massive level, and currently this is what is going on. So the symptoms that they present, the signs and symptoms would be just pain related, but underlying it is the trauma that is undergoing. So I think this is something that we had covered in the last webinar also, but since there are many other people who have not attended the previous one, so just very briefly talk. I think most of you know about it. The fight and flight is all known to everybody. So whenever there's a traumatic reaction, so it is not only during the trauma, but also that teaches you that every time there is a threatening or a potential threat, we tend to become choose one of these modes. So either we are trying to fight actively against the threat, or we try to run away from the threat, or a lot of time it happens that you just go numb, you don't know how to respond to it, or you comply with the threat, or you appease the perpetrator because you believe that that would probably prevent from you getting the trauma again. Okay. So just when we talk about the neurobiology of trauma, of course, it's a human brain. All of you know how complicated it is. There are multiple networks and pathways underlying to various neurotransmitters working into this process. But I will just talk to you about it in a very simple, at a very broad way. And the reason for that is just because you understand how trauma could be contributing into the psychopathology. So as we all know, so thalamus is what is the relay station where all the information goes and the information processing takes place. So from there are two routes that it goes. One is to the limbic system, more specifically to amygdala and hippocampus, and the other one is to the prefrontal cortex. Now this is the shorter route, the amygdala and the hippocampus, and this one is the longer route. So this is so this concept, I have taken it from the book The Body Keeps the Score. It's very beautifully explained there, where the author here has talked about the thalamus as the cooking station. So where the information has come, and I'm trying to and thalamus is trying to process that information. And the moment that information reaches amygdala and hippocampus, remember amygdala is the center of emotions, and hippocampus has the, related to the amygdala, has all the emotion laden memories. So it is, because it's a short route, it doesn't see anything else and rings the fire alarm, and as a result of ringing the fire alarm, the HPA axis gets activated. So your sympathetic nervous system is activated, and your body, your mind thinks that it is an emergency situation. So you are in a alert state, you are in a hypervigilant state now. It is only a little while late, I mean, very few seconds later, when the information reaches the prefrontal cortex, and that is, which is, he has described as a watchtower, which identifies that, this fire is not a threat, it is not another traumatic incident, and it's just probably just a false alarm. And so this is not traumatic, but by then the HPA axis is activated. Okay, and if you now see that in our day-to-day life, during our normal course of life, there are so many triggers, so many stressors that we constantly come across, like I'll give you an example. For example, if somebody who has experienced sexual assault or rape um, is probably traveling by a public transport, and there is somebody who's coming and standing very close to her or him, very close, and it could be just that it's very crowded, and that's why the person is standing. But before you could judge that what exactly is happening, your amygdala has already made your HPA axis activated, where you have become alert that, again, something like that sort can happen. So I need to be alert, have to be on the edge, so that I can prevent whatever is going to happen. So this is just one small example where you are traveling by bus. Similarly, this person could be activated or triggered by so many other smaller things. uh, and every time the HPA axis gets activated, so you can very well understand that the person is almost perpetually living on the edge, is always alert. So every small thing brings a false alarm. Every small thing becomes like it could be a potential threat. And that kind of makes the person, this is what the anxiety is. What if this all becomes a threat? So that maintains that state of anxiety in that person forever, I mean, for the longest period of time. And then that starts impacting your food habit, that starts impacting your sleep quality, your productivity, you find it difficult to concentrate, you're procrastinating, it starts affecting your mood, you're talking to other people, and overall impacts the quality of your life, right? So this is the reason why I wanted to talk about the neurobiology. This is the HPA axis and the sympathetic nervous system that keeps you alert and that perpetually anxious state. So now that we have talked about the neurobiology, let's talk about the psychological mechanism, which is very similar to the CBT understanding. That is not just the childhood information, but anything in the current or the while during adolescence or even the adult life. Any kind of traumatic experience, unpleasant or unfavorable experience, will obviously give rise to some very strong core beliefs. Like I am weak and useless, or I don't deserve love. Because if the person has been experiencing a lot of invalidation of emotions, criticism, or abuse, they might feel that, I don't deserve love. And that there's no point sharing my opinion or my feelings to others, because it will be rejected, or I won't feel, or if the person has experienced a lot of abuse, nobody can be trusted. It is always unsafe around, and I should be in charge of my life. So this could be different core beliefs, would give rise to a lot of conditional assumptions, like if I depend on myself, I won't be able to cope, or on the other way, if I depend on others, I will be rejected or maybe taken advantage of. So there could be multiple types of conditional assumptions depending on your core beliefs, which again depends on your childhood, or your growing up, or your trauma experiences in the past. And this results in the coping of this situation. Again, remember that we are in that perpetual anxious state, so your coping is also in that format, or it is maladaptive, so where you will have excessive dependence on a person, or you will completely isolate or alienate, you won't be trusting anybody, or you will think that you have no agency and you have to completely be dependent on someone. You will be constantly anticipating that what if this also becomes into a trauma event. Because of that, we it's a very common tendency in people who have trauma or who have been trauma survivors to have this excessive need to control, because the very experience of trauma makes you feel so helpless, so overwhelmed, that I have nothing to do, I can't do anything, I can't prevent myself from facing this, I can't stop this. That makes them plan to such an extent where they become very rigid, and they can't think, or they can't change, they can't be flexible, that okay, I think it this way, but then the other person is saying this, so we could give it a try. you know that understanding, or that thing is not there. And then a lot of avoidance, not only of the places or situations, but also of avoidance of emotions, because you think that the more you feel these emotions, it's obviously more distressing for you, so you have a tendency to avoid or to be in denial of these emotions. So, as I was saying, the trauma continuum, it's not actually this continuum, it doesn't go in this order, but it is just to explain the severity, is why I have put it in this way. So, while you're having a traumatic experience, is when you will have the acute trauma and stress reaction, which is normal. Anybody experiencing trauma will be experiencing this. Need not that everybody who experiences trauma will have PTSD, but it is quite common. And then obviously people who have experienced trauma will not necessarily experience complex PTSD as well. So these are things that may happen to a trauma survivor, and the rates are quite high. And if not complex PTSD, or along with complex PTSD, there could be multiple other spectrum disorder that we could see. That is why I was saying that it is important that whenever we are seeing any clinical condition or any psychopathology, it's important that we see it from the trauma lens, that anxiety that I see, that OCD that I see, the GAD, the panic, is it a predispositional thing, or is it so much something that has been induced by trauma, or it is being exacerbated by trauma, or it is getting maintained by trauma. Even the bipolarity, or the depressive episode, substance use, psychosis, everything could be either caused or maintained or exacerbated by trauma, right? So I wouldn't get into the details of this. If there is any question or query later, we can come back to this and we can discuss that what is the basic difference between PTSD and complex PTSD. Now, trying to understand what trauma lens is and what is it what does it talk about? So it's basically it's just a framework, So whenever we are doing the clinical interview, so we learn about how to take a history, how to establish rapport, how to maintain or develop a therapeutic relationship, or do MSc, or do a treatment planning. But all of this we can do just with a trauma lens. So basically a framework where while we are doing the taking the history or doing the MSc or making the plan, we can just think through the trauma lens, think that what if this person have experienced a trauma. So the first step would be to inquire if there has been a trauma, and then to see how, or to have that understanding that if there has been a trauma, that could have a immense impact on that person, and that could happen across the lifespan. Even if the trauma is something that has happened in the childhood, that can impact even today. So it's basically acknowledging that trauma can have a profound and long lasting effect on your physical as well as mental health. And it could be the cause of the onset, it could be the reason for the maintenance, or the exacerbation of the psychopathological conditions. Okay. So this is something that I've explained already. And when we talk about symptom expression, so maybe when we're seeing a case of clinical depression, uh, we know that anxiety symptoms are very common in depression. There are, we don't give a separate diagnosis of anxiety when there is depression because it kind of overlaps. But in some clinical depressive cases, you might find a lot of nightmares happening or night terrors happening, or there is lot of panic attacks happening. Okay, even though the diagnosis is depression, it fulfills all the criteria. There's low mood, there is fatigability, there is anhedonia, whatever, all the symptoms are there. But additional to this, these are the extra symptoms that is there. Okay, that could be because of trauma. Or in usually in depression, we see there's a immense loss of appetite, the disinterest to eat. But there could be some depressive cases where we will see that there is a tendency to overeat or there's a binge eating. That could also again be because of trauma. The third point is very important, that is the reenactment and re-victimization. If we don't see psychopathology through trauma lens, we might end up re-victimizing the patient. Okay, so because we have not seen the things from a trauma lens perspective, my asking, my interviewing, my questioning, my inquiry, everything, you never know how you will re-traumatize that person, or you may not be aware of it, and you might miss out on important things and end up in re-traumatizing them. So that is something that also needs to be taken care of. There could be multiple comorbidity because of trauma. And of course, if we are seeing things from a trauma lens, it is important that whatever intervention we plan, it should also, if we find a history of trauma, it should, there should be a component where we are addressing that. Because I mean, that's a basic understanding of psychotherapy, that where we are not just treating the symptoms, we are trying to bring a positive change, or a there or a positive direction. The change has to be brought into a positive direction. So if you see the objectives of psychotherapy, the three objectives, it will only be fulfilled if we are addressing the inner thing, right? So that is why when we either we use trauma lens, or when we use attachment lens, uh, or when we use a multicultural lens, so these things help us get into the deeper rooted problems and address that, so that it also helps in the relapse prevention. you know it's overall improving the coping, it is overall improving your quality of life. So automatically your psychopath, there is an improvement from your psychopathology. So, if not clinical, typical clinical conditions, but the trauma reactions that can be bordering psychopathology would be hypervigilance, rumination, intrusive thoughts. Uh, there could be so much intrusive thoughts that it might look like that person has it is up to a level of obsession. Okay, but may not be a OCD. Sleep disturbances, there could be panic attacks during sleep, nightmares, flashbacks, difficulty to focus. Okay, a lot of cases these days come up which talks about which which where they are given a diagnosis of adult ADHD, and the symptoms are that there is difficulty in concentration, difficulty in sustaining attention, there is procrastination, not finding interest, uh, and all of this, uh, even though looks like ADHD, if you take the developmental history, you might find that there was none of these symptoms present earlier, and all of this could be just because as a trauma reaction. Okay, so it's important that we just don't see the symptoms at a surface level. That is the reason why we need to understand psychopathology and not see clinical conditions as per the diagnostic criteria. Right, so these are some of the other problems that could happen. Somatic complaints, even to the extent there could be proper psychosomatic conditions that develops in the process. Okay, this is something that I just mentioned about anxiety and depression, how using trauma lens can help you understand why this anxiety is taking place, this anxiety is happening, or why this trauma, depression is happening, or why is it maintained. So, whenever there's a trauma incident, or near traumatic or something very threatening, it will give rise, obviously the traumatic event give rise to all this hypervigilance, rumination, intense emotion, flashbacks. So this kind of maintains the person in a, what we were talking about, in that pervasively anxious state. You are always alert, you are always in a hypervigilant state, as a result of which you will constantly be avoiding, you will be engaging in safety behavior, you will constantly be looking for reassurance, and so that to ensure that you're safe and everything, and this will continue to maintain this loop. Okay, this is how, this is a common manifestation in any kind of anxiety disorders, the entire anxiety spectrum. Now, when we try to see for depression, we know the main symptom of depression is low mood, and also about the negative view about self and the world, right? Now, this remains at the core for sure in depression, but how trauma can maintain this state, you know? So, in trauma, as we know, that there is a lot of avoidance behavior, there's a lot of withdrawal. So, as a result of which, even if you give as therapy, you use the technique of mastery and pleasure, you know, or you do some mindfulness activity, but the reason, because the person is so withdrawal and avoiding everything, the person might give very few opportunities to themselves for good things to happen, which will again ensure that the person remains in this depressive state. A lot of safety behaviors are there, so a lot of avoidance behaviors are there, neutralizing behaviors that again will reinforce this unhelpful behavior, uh, of which I was there in depression from person to person. There's a biased memory, so you will often see, not all but many depressed patients talk about this, that I can't recall the last time when I felt nice or when I was felt any different, you know. So again, trauma can do that. Trauma can add to this overgeneral memory, where you find it very difficult to recall good things. You always think it's all bad, because you are in that emergency state all the time, you are in that autopilot mode all the time. So it becomes very difficult to sit back and relax and reflect and think of what are the nice things that have happened to you. Similarly, when you have a lot of self doubt and criticism and blame, what you will do is you will constantly be dwelling on problems and criticizing yourself, you know. So naturally, you will, what you'll do is, even if you did something nice, you would be discounting that. You will always be discounting the positives, or you will be doing emotional labeling to a large extent, and biased thinking. So obviously the cognitive bias will add to it, which will give rise to a lot of negative automatic thoughts, and those thoughts will add to the feelings, and that will again maintain this loop of depression. So it's very common, you will see that people who have been trauma survivors, they keep having multiple episodes of depression. They tend to have RDD, they have a recurrent depressive episodes, multiple of them. So now that if we have talked about how trauma reaction is, or trauma contributes to the psychopathology, uh, I'll just mention about how, you know, in I was talking about how trauma could be resulting in so many of clinical conditions. So I'll give you an example of another case where this client had she had come with uh, the chief complaints was that she was not eating. She would eat very limited, like, so basically the diagnosis was anorexic, and she had pica also. So she used to eat those earthen pots in which you drink tea. So that was there. So that was the clinical presentation. Okay, this was what came as the presentation, that she's not eating. There was massive weight loss, and that is the time when they had found out that she was also pregnant, and that is where the doctor had referred that client, and then we were working with her, and so when we were talking, all the information that we could get was that I that cognitive belief, that belief system, that I will put on weight, and I am fat, I don't have the right shape of body, and I don't look attractive, etc. So everything that was falling into the place of anorexia. And it was some, I mean, uh, there was anorexia, and I think that was a I don't remember why we did uh, can't remember why I did TAT on that client, but nevertheless, so when I did TAT, what I saw was there was recurrent theme of sexual assault, or a lot of sexual themes were coming up in the TAT. And then much later into the interview, it came out that how she mentioned that how she was there were multiple episodes of sexual assault, and I think, yeah, there were multiple episodes of rape, not sexual rape, by her cousin brother. And her her aunt, whose son it was, the brother, that aunt had once found that. And right after she found, I mean, she found it during the act, and when she found it out, and she what she did was, she asked the son to leave, and like scolded the son, said something, and the son left. And then after that, she kept telling this girl that, you know, how you don't dress properly, or you have bigger breasts. And these were exactly the things that she said, that that she said that I have bigger breasts, and that my body is way too developed for my age, and that is the reason why I attract uh, this male attention. And that is why this happened with me, and that is why he did this, so it is my fault. And that is the time from when she thought that she needs to control her diet, and that she needs to eat less, so that she doesn't put on extra weight, and then she doesn't become a very she doesn't have a curvy body, and that would prevent her from attracting male gaze. And that gradually went up to this level of to the extent where she had eating disorder. So if you just take it at an anorexic level, if you just take the diagnosis as anorexia and you start doing your therapy, uh, I feel, obviously, definitely you will do progress and you can work through it. But if you take the trauma into the picture and in your therapy planning, I think the treatment outcome will definitely be much better, because you are addressing the root cause of why this person started with uh, this where this belief started coming from, where this how did this core belief form, so again, so that's what. So every time we have seen in every whenever we've studied all the disorders, that how in the etiology trauma is mentioned, if we have read it, it is not just there for that. It is also our job to address that in our clinical practice, not to just know that, oh, these are the causes, so to address that to inquire about that in our clinical practice, so that we can incorporate that in our planning of the management. uh, so we'll talk briefly about what these three terms are. Uh, there is a lot of confusion between trauma sensitive and trauma informed. A lot of times may be used interchangeably, but they are very different concepts. So trauma sensitive basically means that you having the awareness, that what and how a trauma or traumatic experience can impact, and how it can impact your physical and mental health, and how it can impact across lifespan. And it need not be that you have to take any action towards it. That is just being trauma sensitive. But trauma informed is where you are just taking an approach of life, or you're just taking that framework. So when you are doing in a clinical practice, you having a trauma informed approach to it. So you're just putting this awareness or this knowledge of the pervasiveness and the impact of trauma into practice. Okay. And trauma specific is basically the different interventions that are there, which are evidence based for trauma. And also to keep in mind that when whatever the interventions I'm doing, I am keeping a segment specific to address the trauma, so that it can improve there can be a better treatment outcome and result in better post traumatic growth. So, what trauma informed care? I think it's now quite clear from all the discussion. So, it's basically understanding the impact it can have and providing support from that understanding. So, it is important that you recognize the trauma symptoms and you have that genuine, authentic, and compassionate relationship. So, these are the 4 R's of trauma informed care that we talk about. Number one is realize. So, to realize that trauma can have a very long lasting and very major, massive, monumental impact on a person's life. And to what extent and how, we don't know. It is very personal, it's very individual. So you also have to realize it individually. You can't have a umbrella understanding of it. You have to inquire and see for each individual or the each client that you are working with, to recognize those individual symptoms. So the trauma, as we talked about, so there are multiple trauma reactions, right? uh, like if you see the diagnostic criteria also, you will see there are three core symptoms, but there could be multiple others. So it says there could be emotional dysregulation. Now emotional dysregulation can be in several ways, right? Sleep disturbances can be in several ways. So each one will have a different kind of a clinical presentation. So it's important to recognize the symptom, then obviously respond with a trauma lens, respond in a trauma informed care approach, and also to resist the re-traumatization, because this is also again very critical, because this is a very sensitive thing that we are addressing. If Make sure that if you are not competent, if you are not equipped with this approach, don't attempt to do it, because you might end up in a re-traumatizing the person. So it's always better to grow, develop those skills, and then start working with that. But you can always have a trauma informed approach or see things from psychopathology through a trauma lens. Okay, so one of the most important thing when we are doing a trauma care or a trauma informed care is to do crisis intervention, and so we can call that as a psychological first aid. There are multiple ways to it. The basic principle or the basic tenets remains the same. So this is the lives model, this is the lives approach. This was given by World Health Organization, WHO. This is basically an acronym. So it talks about listening, the listening skills, that when you are talking to a trauma survivor in a therapeutic space, you have to have very good active listening skills. You have to have very empathetic listening skills. So you should be not only listen to the person, obviously you will actively be listening, but at the same time you have to also ensure that the client knows that you are listening. So you could make some gestures, or you could nod or say or something, so that that the person gets just give me a minute. um, Sorry. uh, uh, yeah, so to make that person aware that you're listening, there could be a lot of pauses and silences in between while you are talking. So ensure that you respect that, you know how to handle those silences, those pauses. Inquiry, very, very important. So a lot of times we might end up assuming, like if the person has come with such a traumatic experience, the right course of action, or this is what should be done. But maybe that person has not come to you for that. Maybe that person is not ready to take any course of action, and the person has come just to vent out to you. So inquire about what is the reason or the purpose of visit, or ask how can I help you. So a person who's come with uh, as a survivor of domestic violence and comes and sits in front of you, you can see bruises and everything, and as a normal natural instinct, it would seem to you that this person family and has to stay away, go take legal action, take separation, everything, which is true, which is very logical, rational. But maybe not now. Maybe the person is so traumatized that all the person cares about is to have proper food and sleep, which is what the person has been deprived of for maybe 4 days or 5 days. Okay, just the normal biological functioning is all that the person is looking for now. So don't. So depending on what the person looks for is what you have to inquire about it and not assume. Validate, it's very important. Validate their emotions, their feelings, their thoughts. And sometimes, mostly, try to validate things verbally. Acknowledge their feelings, and never say things like, like, uh, I know the people experiencing such things find it very difficult. Don't make it like, make them feel that you're not the only one feeling this way. There are a lot of people. I know that may give them a hope. At that point of time, their experience is so devastating to them that they don't want to know whether it's other people also have it or how it works and everything. All they care about is that basic acknowledgement and the validation that they get. You have to ensure the safety. Okay, now if there is an active violence going on, obviously you have to ensure that the person is safe that way and doesn't experience more violence further. Or if the traumatic experience has happened earlier, right now there is the person is engaging in a lot of self harm behavior, so you need to address that first. Or there is very active suicidal thoughts present, so you have to do a crisis intervention or active suicide management, whatever the, if needed, gatekeeper monitoring or whatever is needed. So you have to ensure that safety first, and the social support facilitation. So connect them with the, so again, with trauma there is a huge chance of them alienating themselves because of the blame, that the guilt that they have, uh, grossly wrong with them. That is why they are feeling this way. So connect them, try to connect them with their friends, their family. Also, before you do that, you also need to discuss that how much of your trauma experience do you want to be shared with these people. Okay, it could be that they don't want the event or the description of the event to be talked about. It is just that they need some support during this state that they're going through. So maybe that kind of facilitation is needed. Or maybe you can connect them to different support groups that are, it could also be not just social support, but otherwise also you could, if the person requires whatever necessary referral is needed, so do facilitate that. So these are the basic things that you need to do before you move on to any proper intervention, before you plan any intervention, whichever mode of therapy you go for. Before that, this is something that has to be ensured. So this is the trauma informed care principle that are followed. One is ensuring the safety, as I said, giving them the autonomy, which is very, very important, which is about was talking about, while you need to give them the autonomy and the choice that they have a control. It's their life, they have the choice to choose what is to be done. They can, because as I said, there's a lot of doubt and self blame and guilt. So there is, as in whatever skill building is required for that person. Okay, uh, again, to develop their interpersonal relationship, have more connection forms is also needed. And also make, share, I mean, there has to be a better understanding of the power and the decision making into the process, so that their typical view of self and others in the world, all of that doesn't come into the picture, or doesn't color their entire decision making and the power structure. So giving that, so for that you might need to collaborate with them to help them find the right way to deal with these things. So this could be some of the common steps of the trauma informed care before you plan to go for sorry before you go for any way of treatment. I mean, you choose one mode of therapy, be it CBT or be it narrative exposure or cognitive processing therapy, any of the therapy. So first you have to understand the context of the trauma. So is the trauma due to a natural disaster, or is the trauma due to some kind of violence? So these are two very different things. So if the trauma is because of violence, then it's a very systemic problem, where even though the person will hold themselves responsible, and the entire process goes and the narrative goes that way, you have to understand that it is this individual, maybe this particular individual is the one who's traumatized, but it is not that individual problem. It is a it is at a much bigger macro level. So to understand the context of the trauma, only when you understand the context of the trauma will you understand what could be the symptoms, or why this person is experiencing typically these responses. And when a person experiences trauma due to an earthquake or any kind of natural disaster, very unlikely you will see a person having shame or guilt. But if when a person is experiencing rape or has experienced domestic violence, the chances of this self doubt or these self negating thoughts are more common. So you need to understand where this trauma is coming from. Is it at an individual level, or it is at a systemic level? Then you have to obviously recognize the severity and the impact of the trauma. How much has it impacted? Has the person completely stopped going to work? So the occupational aspect, the interpersonal aspect is affected, even if the biological functioning is also impacted. So that needs the restoration first, right? So you have to understand how much and what is the severity and the impact of the trauma. Acknowledge and validate. Do a very thorough crisis intervention. If there is suicide risk, include that part as well in your crisis intervention. Then implement or plan first and implement the trauma focused therapy. Whatever mode of therapy you choose, you should have the part of addressing related reactions, which is contributing in some way or the other to the psychopathology into your therapeutic goals. And lastly, you have to identify the post-traumatic growth. So you should be continuing the trauma-informed approach or the care unless the person has reached the post-traumatic growth phase. It's a safety and stabilization. So reducing risk of self-harm, their risk of suicidality, ensuring that they are gradually becoming on normal, not getting into the normal course of life. Once that is done, only then you will go to the processing of the trauma. It could include remembering, processing, grieving, whatever. And finally, again, making things uh, reconnecting and integrating them. That is, you don't have to put a lot of extra effort to continue with your normal course of life. It should be coming naturally to you because you have processed and that the trauma part has been resolved. Even though there is, after all of this, there will be a part of trauma that remains with you. The memories will be there, the emotion will be there, and all of it will be there. But you will be better integrated and you will have a better acceptance of that. So that it further. Okay. So I think that is what the content of the webinar is. So we'll stop.
Sampurna. Yeah, I think uh, you had some problem with the internet uh, in the last part. I guess everybody could get the last part. If anybody wants any repetition of the last couple of slides, you may ask. Otherwise, I think it was more or less everything was visible and audible. Right. Yes. Okay. Yeah. So we have couple of questions. Sampurna will straight away get to the questions now.
Sure.
Right. So if you can also open the question and answer section on your laptop, you will be able to see.
Yeah, I've opened it.
Yeah. So you can take one by one.
Okay. So I think there's a question that does trauma can even lead to excessive daytime sleepiness? I think, yeah, it can. I mean, uh, not something that I have seen in my clients, but it could be like it can manifest in any form. So it could be one of the symptoms. Mm, name of the book? Which book? I don't. Which book? I don't know. We're talking about. Okay. How did she develop pica? Okay, so that the pica was mainly from the It was more for a physiological reason. There was a lot of the deficiency. It's very common, if you see uh, in eating disorder patients, they do develop a lot of pica-like symptoms. So that was the reason for it. Mm, okay. So re-traumatization. Okay. So what happens is, suppose, for example, if a person has experienced, again, I'll go with that example of rape or sexual violence or a kind of sexual harassment in the workplace. Okay. So now when the person plans to report it, so the usual procedure is that first, suppose you go to the police station. For example, you go to the police station. You say everything. Usually what how it happens is you first give an entire description. First they'll just listen to you verbally, and then they will start, making the noting down things. So it's like already once you have experienced it, then the second time you are telling it, or right, giving a written FIR, then you will be obviously sent for medical tests. There again, all over again, you have to say the same thing. Then when the case goes up to the court, you have to repeat the same thing to the magistrate. Magistrate or the court sends you for any kind of help, counseling services, then again you go and say the same thing there. So in the system that we have here, at places where the same event, the same traumatic event has to be repeated several times by a person, and which obviously adds to the re-traumatization. So it's, as clinician, what we can do at the best is, I think two things we can do is, so whenever with is planning to go for legal course, or taking legal action, you need to prepare the client. You have to make the person aware that this is the procedure that works here, and this is how it is going to be, and you might be required to repeat it and say it so many times. And during the process, if any time you don't feel comfortable and you're not anymore willing, you can back out at any point of time, even after you've done a FIR, and then it seems very overwhelming to you, and you don't want it to be a court case or a legal case anymore, you can withdraw at any time. So giving that knowledge and the information to your client is one way you can prevent the, so you're kind of, obviously you can't eliminate entirely, but you can prepare them from having the entire brunt of it. And the second thing is, if, as suppose you are seeing the client, and then you think that the person reads a referral to a, for medication, to a psychiatrist or a gynecologist or whoever, so you can give the brief, or if consent of the client, explaining that, so that you don't have to go and say it again. If whatever I have documented, if same thing you wanted to be shared with the the person, referee, if that's okay with you, medication also, and I would like to refer you to a psychiatrist, or could you just find yourself one and go there. And they're also, I don't want to say the entire thing all over again. Okay. So that, and also it could be happen that sometimes you might require to, you maybe not be able to continue doing it, doing that before that person, or continue with the treatment. So it's important that you maintain the documentation in a very proper way, because be aware that these cases can often become medical legal. So if you have a very good documentation, that might help in preventing the person to go through the entire record, the narrative again. But that might not work as well again, because a lot of times this is how the legal system works, and that's how it goes. So I think that in those cases, informing and making the person aware of this is how it is going to be would be very important. Okay. While working with trauma, there are certain times when their intention is valid to me, and they wish to feel more regularly. How do we work with this? Responses such as anger at a caregiver feel very valid to them. Yeah. Yet they wish to feel more regular during such conflicts. So you probably have to address why they are having such intense emotions towards the caregiver, and what part of that caregiver or what process of that caregiving is interfering and is making them experience such intense emotions. You need to work on that, and only when you find that, help the person regulate such conflicts better. Of course, there could be some distress tolerance and better emotional regulation skills that can be done, but then also that would work very at a very surface level, only till a limit. There would be again uh, how to reduce magnification in clients to bring about a shift in clients' thoughts while addressing the problem and maintaining a trauma sensitive approach. I think it's the same way, the way we address magnification. Give scenario audible. Can I?
Yes,
Can
Purna, your voice was breaking in the middle, little bit. If you can switch off your video, that would make it better, I think, and you can continue talking. Yes.
Yeah. Okay. So what I was saying is, with magnification, it's the same way that the way we work in other cases also with cognitive biases, we could be using the same thing. Uh, Having a trauma sensitive approach would just mean this magnification is happening because of the trauma. So maybe making the client more aware of the reason why the person is having so much magnification or discounting of positive and all of that will give them a better perspective of why these cognitive biases are coming over and over again. And then they themselves, you can make them apply other alternate responses in the process. Okay. Okay. Next is, what is gatekeeper, not gatekeeper monitoring. What I was talking about is gatekeeper training. So, suicide prevention, when there are people with very high suicide risk. So, kind of making people very close to them, like the family members or their primary caregiver or somebody, prepared to how to deal with such high suicidal risk situation. That is a separate kind of a training that is done. As a clinician, you can do that to your informant, I mean the client's informant. And how to do psychological first aid is, I think, something that I mentioned in uh, the webinar, I mean in the presentation. Oh, okay. The book was The Body Keeps the Score. Yeah, the book is Body Keeps the Score by Bessel van der Kolk. Okay. So to get the about trauma. So, while you're doing a clinical interview, this is something that I do with all my clients. So the way, while I'm doing my clinical interview, the way I assess for suicide risk, I also inquire about trauma, and I just give a very brief context before that. That's saying that that uh, uh, this is just part of my routine. Asking how I'm interviewing and how I'm asking you about your family, your development, your growing up, about your growing up years, your work, and everything, every aspect of your life. So I would also want to know that if ever you have experienced any traumatic experience, because it's quite common in a lot of people. And if that is the case, it has a huge impact on our mental and physical health. So it would help me understand the case better, and help me plan the intervention with you also better. So I would like to know a little about the trauma, but also at the same time mention that if you're not okay to talk about it as of now, maybe they may not be comfortable to talk about it in the first session. or the second session. So just keep it a point that you tell them that you want to know about it, and that could be a potential factor in your intervention planning. So they will know, and whenever they are comfortable, you can talk about it. And if you mention that, it has happened with me a lot of times. I talked about it, and then many sessions have gone by, and then one session they just randomly said that, I wanted to talk to you about this, and I wanted to tell you that this happened to me in childhood, and I've never discussed about this with anybody, but this is something that has happened. So it will come like that. If there has been a repression of the event, uh, there could be a lot of trauma reaction, multiple ways. There could be a lot of unexplained emotional dysregulation. There could be a lot of fluctuations in mood. There could be very multiple maladaptive coping. There could be like binge eating, or substance use, or a lot of those things. So if our part the patient is living with their abuser in a domestic violence scenario, how do we go about that, especially when they are not wanting to leave? So as clinical psychologists, our job would be to tell them that these are the different way out. If you go for a separation under the DV Act, these are the things that these are. If you don't want to uh, just not, if you don't just take a separation, you also want to file a case, then these are the options, and at the same time these are the difficulties that you will be facing in the process. But at the same time, you should also be mentioning about how this could be compromising with your, or if there are children, their safety. So what is your plan, what is your safety planning? So how you could be involving the family members or some friends in the process, or there are many these one stop centers by the government, so you could ask them to reach out to these centers, so uh, or never, you should never say, tell them that you this leave, never say that, but you always have to give the different alternatives to the person and let them decide what is to be done. But with each and every way out, you should also give what is the way forward, and what are the risk or the difficulties they're going to face if they choose that course of action. That also need to say. uh, um, if it wouldn't count, I mean, it could be so that is the reason why when a person is having a lot of active flashbacks and panic attacks and everything, we do not usually suggest mindfulness or relaxation. So you need to know where you have to be careful when you are suggesting mindfulness or relaxation. But a lot of mindfulness technique, particularly grounding technique, is something that really works very well. So when a person is feeling triggered or very feeling very traumatized, they're having a lot of flashbacks or panic attacks, yeah, to practice grounding. That there are multiple ways of grounding. The five senses grounding, there's grounding bag, or a lot of those things are there. So that can be done, and you can always tell them that if you are feeling triggered, or while you are trying to relax, those thoughts are coming way too much, you can stop, you don't have to continue the process. um, to talk a little about trauma bonding, I think it's a very huge topic, and well, I mean, it's completely a different uh, uh, topic altogether, which will require one entire session probably.
This has
And
actually
I don't
given us
think
the
there are very
idea for the
specific,
next topic. Next
yeah,
webinar we can do on this.
yeah. And I think interventions, there are no specific intervention, particularly for trauma bonding, but if while you're doing working with a client and you see there are certain trauma bonding there, and there is that is something very that is contributing to the pathology, then whichever intervention you take, you can address that. But just some bonding, I would go with interpersonal therapy, but use some mentalization based techniques. So, but that just suddenly, like just now, that came to my mind. So that much I can say. Okay, so there are some of the resources that you asked for. There are quite a good few materials. If you been given by the Sanctuary. So if you go to their website, it's called the Sanctuary only. You will find by Bloom. You will find quite good material, and trauma. There is a very good material by WHO as well. You just have to type trauma informed care, and you will get a lot of this good material available. Uh, there is one, I think, by UNDP as well. So I think you will find it. These are readily available online. Even the psychological first is one by WHO, one by UNDP. All of this you will find online. These are all freely available material. Uh, yeah, I think the pre-morbid personality and then the trauma obviously will make the situation even worse. So it's more work required first to work on the symptoms, reduce the stress, then address the trauma, then work on the personality, then integrating all of it and trying to make a positive change. So it will be a very lengthy process, I think. Very difficult to mention any few techniques like that. It depends very much on the personality. Okay, so yeah, it does happen. The client might ask you to come along or help you in the process, or if not this, faced very often with all my clients who had earlier when I was working with all IPV survivors. They would often ask me that if I could talk to their husband once over phone and tell them and explain to them, you know. So two things. One, you have to explain to them that your roles and responsibility, your responsibility in the role is restricted between you and just the client, and you have ethics that where you can't go beyond. That's one thing. And the second thing I can talk about is that this might, if the person asks you to talk to the family member or somebody, this might increase the chance of you experiencing violence even further. So that is also something that you can restrict. Sometimes they might ask you for this, like to come along to the police station or something. Again, you have to highlight more on the specific ethics and the responsibilities, and very assertively you can say that that is not something that comes under the purview of your job and you won't be able to do it, but whatever support this person requires, you are always there to do that. Okay. Reconnecting and reintegration is, so initially when we start working with trauma survivors, we try to reduce their symptoms, the distress, and then we try to make them do get back to the normal functioning. We may do relaxation techniques to reduce their distress, or do grounding, as I said, or maybe do mastery and pleasure activity, behavioral activation, and all of that. So these are things that to put active efforts to do it. That would be something that would come naturally to like they will feel again that alienation that they were facing, or the kind of withdrawal that they were experiencing, they automatically will start reintegrating again. the the recovery has taken place. So that is again true for even when we are talking working with grief counseling or complicated grief, the same thing happens. So there's a reintegration that happens, which will happen as a more spontaneously, and you don't have to use any techniques for that. So the process has completed and it is happening spontaneously. On intervention, so uh, depending on which intervention you want to work on, again, there are many materials present on that. There is narrative exposure therapy, so there are books on that. Uh, um, I do have some books. I can't just recall right now. If possible, just reach out to me personally on, like, you can email me or send me a message on LinkedIn. I will send you the link of the books, or I'll just mention you the systematic desensitization. Uh, I don't personally use it, systematic desensitization, as a technique for PTSD, because I feel that already, especially if they're so a client to you will come with PTSD only when they are having very active symptoms. So it is when when the person is in that state, it is very uh, it's very distressing for me also to induce that amount of anxiety and do that response prevention. So I don't use systematic desensitization, and I don't think that it's a very good evidence based technique also to for PTSD. Yeah, I think I've answered all the questions whatever was there.
Yes, yes, you have indeed. There were many questions, so that's very good to see that people have taken interest in knowing about it more. And this remains to be in very, like, still remains to be very interesting topic. And still a lot of things are still unanswered. And with PTSD, what I feel, it requires, like, apart from the theoretical knowledge and the teachings that you can get from your seniors and your educators, the practical experience that you can really get being with the patient and experiencing their recovery as a therapist yourself. So my personal advice would be that whenever you are seeing a patient of PTSD, definitely make it a point to somehow increase the compliance and stickiness of that patient with you, even if it requires for you to make some adjustments to keep having sessions with them, because the kind of recovery that you will see and the kind of things that you will see that patient going through, that will be a textbook in itself. So yes, PTSD, definitely reading the books and getting practical advices will not be enough unless you go through yourself as a therapist. Right. There were a couple of polls also I did, just basic questions. So I have just published the results. Is it visible somewhere? Yeah. Okay. So the first was PTSD can only be diagnosed after first month. So this is the closest true and false. So true was 58% and false is 41. So yes, PTSD as per diagnostic criteria is can only be diagnosed only after 1 month. Before first month, it usually falls in the category of acute stress disorder, and also adjustment disorder if the intensity is even milder. Right, so in one spectrum, adjustment disorder, acute stress disorder, and post-traumatic stress disorder, it exists. uh, are they different, PTSD and ASD? Yes. So the answer, this question is answered itself. Is it required for a person to directly experience the trauma to get diagnosis of PTSD? So not. DSM-5 has stated it's directly experiencing it, witnessing it, indirectly experiencing it. So still it's valid for the diagnosis. PTSD has 4 symptom clusters: intrusion, avoidance, negative alterations, and arousal symptoms. So these are the four symptom clusters. One in each has to be present in PTSD. And I think, if I'm not wrong, in ASD, it's not required for one in each. It's overall 9 out of 14 symptoms should be present. So PTSD there is a very demarcated and very clearly defined, that why PTSD and why when is ASD and when is PTSD, right? One of the thing that Sampurna, you mentioned very interesting case that you mentioned about the sexual assault that the girl had gone through, and which landed up into eating disorder. That was really interesting, and only after the projective test it was revealed. So that also is very appropriate towards the question that was written, that how, when it is repressed, when it is repressed, how can you really reveal it? So projective test definitely is one of the thing, if you're suspecting as a clinician that there is something not right. So usually, as you gain experience as a clinician, so one thing is very certain, there will be a gut feeling in you which will tell you that even though it's a eating disorder, there is something not right, that there is something that is not being revealed by the patient, and that comes with experience. And I would say a very good MSc, mental status examination, still remains your go to tool. If you really conduct that mental status examination delicately and in a detailed manner, you will have lot of findings to suggest that there is something which is not being expressed by the person. It often happens. The trauma is not expressed very immediately. And similarly, in the same spectrum, the question that was asked was, how do you actually ask the question or to reveal the content? It was taught by my HOD that it you can always ask them by stating a fact, that it's often seen that when a person has gone through a particular incident, they never remain the same. It is often seen. So the person would get a validation that yes, it's often seen, so maybe it's happening with me as well. So the person might land up telling you, right? So similarly, the question should never be if you drink or not. Sometimes the question should be how much drink do you take per day. So it's like more towards the validation side, right? Yes. I think we have finished it in time almost. We do have an upcoming webinar. It's on the screen. It's about being an online therapist effectively for an upcoming era. Being an online therapist now is not to be taken casually. It has to be taken seriously. And how we can do that, what tools we can use, how we can participate with the patients online, but equally professionally. So that is something that we are going to take up soon. And maybe, yes, trauma bonding is something that has come up through the questioning. So Sampurna ma'am might again accept the invitation, and she might take that topic as well. And the recording of the webinar will be uploaded on YouTube. So you can follow us there on YouTube channel. You can follow us on Instagram, LinkedIn. So we will post it everywhere, wherever it's possible. And people who have been there with us for significant time in this webinar, we will issue the certificate personally as well, signed by the presenter. So thank you guys. Thank you so much for being part of this. And thank you, ma'am. Thank you, Sampurna ma'am, for accepting the invite and yet again delivering such a wonderful webinar. And we hope that we continue to have this series of webinar on behalf of Yes Mindy, and we intend to build a very closer community, as Yes Mindy stands for Mental Health Fraternity. So let's hope to see you guys soon, and we'll keep on improving. We'll keep on doing better for you guys. And as seniors, as experienced clinicians, we are always there to help you. Right?
Yeah.
Yeah. Thank you
Okay.
so much,
Thank
guys.
you, everyone.
Okay.
Thank you for giving me that opportunity and all the amazing questions and the audience. Thank you very much.
Yes, indeed, indeed. Thank you. Bye.
Okay, bye.